Hey everyone, my name is Chris and welcome to RSCP High Yield Concepts in Radiology. Today I will be going over cirrhosis. Cirrhosis is a chronic irreversible condition that is marked by permanent fibrosis of hepatic tissue causing a decrease in the liver's metabolic function. There are a myriad of causes that can lead to cirrhosis, but the most common causes are chronic alcoholism and viral hepatitis. A few other causes are listed on this slide. Depending on how well controlled a patient's cirrhosis is, they can present asymptomatically or with mild nonspecific symptoms like anorexia, weight loss, and fatigue, which we would call compensated cirrhosis. Or they can present with the classic symptoms of liver function deterioration, which include jaundice, variceal hemorrhage, ascites, hepatic encephalopathy, and hepatorenal syndrome, which we would call decompensated cirrhosis. A few physical exam findings that may be present in a patient with compensated or decompensated cirrhosis are asterixis, ascites, spider angiomata, jaundice, scleroicterus, hepatosplenomegaly, and palmar erythema. These patients may also have an elevated total bilirubin, an elevated INR, thrombocytopenia, hyponatremia, and a normal ALT, AST, and alk phos. Although the HPI, physical exam, and lab findings may support a diagnosis of cirrhosis, imaging and or biopsy are required to make an official diagnosis. Ultrasound, CT, and MRI can all be used to support and or diagnose cirrhosis, and each modality has its pros and cons. Ultrasound is a cheap imaging tool that can screen high-risk patients for cirrhosis. It provides good vascular evaluation of the liver as well as provide a good assessment for portal hypertension. Elastography, like FibroScan, can also assess stiffness and fat of the liver, which can be used to detect changes of cirrhosis with time much earlier than CT and MRI. CT generally provides good assessment of cirrhosis and can provide a more complete assessment of other abdominal organs such as the pancreas and bowel, which are normally not seen on ultrasound. However, CT is insensitive in early cirrhosis. MRI finally is the most sensitive tool to screen for hepatocellular carcinoma, however, it is also the most expensive. The reason why it's important to diagnose and monitor the progression of cirrhosis is because of the risk of hepatocellular carcinoma. The Liver Imaging Reporting and Data System, or LIRADS, is a system that uses radiological images to assign a score of a patient's risk for this progression. I won't go into too much detail, but essentially the higher the score, the greater the risk. If you're curious, there is a 25-page document for ultrasound LIRADS updated in 2017, and a 60-page document for CT MRI LIRADS updated in 2018 that you can find on the American College of Radiology website. Now, let's go over a few images. Here are a few grayscale ultrasound images of a cirrhotic liver. In image number 1, you can appreciate the heterogeneous and coarsened echogenicity of the liver, meaning that the liver has a few dark areas and a few bright areas. In the second image, you can appreciate hypertrophy of the caudate lobe and lateral segments of the left lobe and atrophy of the right lobe, which are common findings in cirrhosis. In the third image, you can appreciate the irregular nodular contour of the liver right beneath the subcutaneous fat. In a normal liver, the liver edge should be smooth. Here are matching CT findings of the cirrhotic liver. You can appreciate the irregular nodular contour of the liver in the first image, and also the hypertrophy of the caudate lobe and the lateral segments of the left lobe in the second image. As stated before, you can also assess portal hypertension with ultrasound. In the first image, you can appreciate slow biphasic flow in the portal vein, which essentially means that the blood flow is moving forwards and backwards. This can be seen with the red and blue colors on Doppler, and normally the portal vein has continuous forward flow unlike systemic veins. Doppler ultrasound can also help identify the establishment of a portal systemic collateral, which can be seen here in the second image, which is a recanalized paraumbilical vein. The third image shows an enlarged spleen indicating splenomegaly secondary to portal hypertension, and the fourth image shows anechoic fluid outside the liver, which is ascites. Again, here are matching CT findings of portal hypertension. In the first image, you can appreciate gastric varices at the tip of the red arrow. In the second image, you can see an enlarged spleen or splenomegaly. In the third, you can appreciate a splenorenal shunt, which is an abnormal but common portal systemic communication between the splenic vein and left renal vein in portal hypertension. And in the fourth image, you can appreciate the hypodense acidic fluid outside the liver. Here's an MRI of a contrast of a cirrhotic liver, and you can appreciate the higher quality imaging. The first picture is an arterial phase image, which shows the arterial enhancing lesion at the tip of the arrow, while the second picture is a delayed phase image, which shows the internal washout of contrast with pseudo-capsular enhancement. This lesion in particular would receive a LIRADS score of 5, which is diagnostic of hepatocellular carcinoma, so in this case, a biopsy would not be required to confirm the diagnosis. The management of cirrhosis is to slow down the progression of liver disease. This can be done by treating underlying liver conditions, if any, such as viral hepatitis and metabolic liver conditions, and to treat conservatively by stopping alcohol and other hepatotoxic agents, prescribing non-selective beta blockers, lactulose and rifaximin, and staying up to date with vaccines, although beta blockers would be contraindicated if the patient also presented with spontaneous bacterial peritonitis. If a patient's portal hypertension cannot be controlled conservatively, they can have a transjugular intrahepatic portosystemic shunt placed if the patient qualifies. Therapeutic paracenteses can also be used to help decrease discomfort from recurrent ascites. The ultimate cure for cirrhosis would be a liver transplant, and a hepatologist can use the Child-Pugh or MELD scores to predict cirrhosis prognosis. Here are my references, and I would like to thank Dr. Kevin Hyatt for the images and his guidance. Thanks.